Premature junctional contractions. Our objectives: identify the origin of a PJC in the cardiac conductive system. Recognize a PJC on the ECG monitor. Describe the difference between a PJC with a capitulatory pause and a PJC without a capitulatory pause. And describe the morphologic difference between the P waves of a PJC and the P waves of a normal sinus rhythm. Premature junctional contraction is a junctional complex that occurs sooner than expected in the underlying cardiac rhythm, just like a PAC that we've talked about previously. This is due to increased automaticity in the AV node, and it's usually associated with non-compensatory pauses. So this means that the cadence or the underlying rhythm of the SA node will actually reset, a non-compensatory pause. Compensatory pauses can occur with PJCs. Most of the time this happens when there's no retrograde conduction like we talked about in the previous lecture. PJCs can occur in a single event, or it can be recurrent combinations. And the coupling interval, which is the distance from the PJC to the previous QRS complex, can be fixed or variable. A fixed coupling interval is the same whenever an individual ectopic focus fires, but when you have multiple ectopic focuses or foci, then you could have a variable coupling interval. So this figure here actually shows a PJC, even though we haven't started really looking at them yet, but this is what you can expect for a textbook PJC, where you have no P wave, but you have essentially a narrow QRS. When determining, you've got a premature beat, and you're determining is it a PAC or a PJC, number one, always look for the morphologic variation in the preceding T wave. Let's see if the T wave has been merged with the P wave, and you're going to do that by comparing the other T waves across the strip itself. Look at the pauses. Look for inverted P waves, and if you've got a 12 lead, which is one of the objectives, is to determine why it's important for us to have other lead views when we're looking at these arrhythmias. But when you have a 12 lead, or if you just take a look in leads 2, 3, and AVF, you'll see inverted P waves, oftentimes with short PR intervals. This is a example of a PJC. So there's no P wave. It's most likely buried in the QRS complex. Whereas here, you've got a buried P wave in the T wave, which actually affects the morphology of the T wave. So you take that T wave and compare it with that T wave, and what you actually see is that you've got a premature conducted beat with a P wave that's actually heightened the size of the T wave. Identifying aberrantly conducted PJCs. So this is going to be PJCs that have been conducted off of a different track than the normal track. Aberrancy occurs when a normally transmitted depolarization wave travels down the electrical conduction system and hits an area that is refractory to impulse transmission. The impulse must then travel the rest of the ventricles via direct cell-to-cell transmission, so it doesn't go down the conduction pathway. This figure right here shows a normal sinus complex followed by an aberrantly conducted beat. The initial milliseconds of both complexes are identical. Because the early portion of the QRS complex is always transmitted down the normal electrical conduction system, the portion will always be identical to the normally conducted complexes. But look on the back side of the complex here. The number of milliseconds that are identically transmitted depends on the site of refractoriness that causes the aberration or the detour of conduction. If the refractory site is very close to the AV node, the amount of time will be very short. If the refractory site is further down the electrical conduction system, the amount of aberrancy will be longer. So what are my rules for premature junctional complex? We need to understand that there is going to be an underlying rhythm, and then we're also going to have the PJC. So the rate is going to be the rate of the underlying rhythm plus the PJC. The rhythm is usually going to be regular except for the premature beat. So you'll have an irregular R to R where the premature beat occurs. The P wave before QRS in the PJC will be either inverted or absent. And also the underlying rhythm is going to determine that as well. The length of the PR interval is usually less than 0.12 seconds if the P wave precedes the QRS, and it's absent if no P wave occurs before the QRS and the PJC, and then the QRSs should look normal. So here's an example of a PJC. Going through our steps for rhythm analysis, we're going to look at our rate. So our rate is 80. My rhythm. So if I were to take my calipers and look, I could already tell that it's irregular because I've got a disruption in the R to R interval where that first premature complex occurs. So it's irregular. My P wave for my underlying is positive, uniform, but for the PJC it's absent. Most likely it is buried in the QRS complex there. What about my PRI? Well, my PRI for my underlying rhythm appears to be about 0.16, and then my QRS looks normal, and it looks like it's about 0.10. But when I look at it, I notice my irregularity, and I notice that I've got a PJC here, and then I've also got a PJC right here as well. So this would be a sinus rhythm with PJCs. What determines a PJC here is that I don't notice an upright or a sinus P wave. So the differential diagnosis. What can cause the PJCs? They can be idiopathic and benign. So most of the time they are. Anxiety, fatigue, drugs, nicotine, alcohol, caffeine, heart disease, electrolyte disorder. So a lot of the copied and paste differential diagnosis of just about all the arrhythmias we've seen so far. So let's look at a couple of examples. So if we notice in this figure here, we've got a rate of 1, 2, 3, 4, 5, 6, 7, 8, a rate of 80, and it is irregular because I notice that R to R. My P waves, they look normal for my underlying rhythm. My PRI looks to be about 0.18, and my QRS is about 0.10. So I've got a rhythm that's underlying, and then I've got a PJC that occurs right here. I don't see a sinus P wave. I don't see a P wave that's upright that looks different. So I have a PJC right here. So this is sinus rhythm with a PJC. So this figure here, it shows a sinus rhythm with some ST segment abnormalities, which could be due to the digitalis effect like we talked about with atrial arrhythmias, the ladle-like or scooped out appearance of the complexes. You've got two premature complexes where the blue arrow is pointing, and they're slightly different in morphology. The first PJC has some aberrancy. The height is slightly shorter, but so is the fifth complex. The terminal S wave and the QRS complexes of the third complex may actually be a buried inverted P wave. The morphology of the second PJC is exactly like the normal ones. So in this case here, I note that this is not a P wave right here, because I see that I've got this scoop here and the scoop here. So that's actually a T wave, but there's no fusion of the P wave right there. And so this is a T wave too that kind of goes into that complex. But so what you've got here is an irregular rhythm with sinus, because you've got underlying P waves with PJCs. So in this next example here, we see a sinus rhythm that's going along pretty well, and then we've got this beat that appears prematurely. which indicates a PJC. This one's got a little bit of a wider complex here, but it's an irregular rhythm, and it also has a PJC as well. Now note, we have multiple PJCs. This shouldn't be confused though with a PVC that we'll talk about in the future, because it still is pretty narrow. There's no P wave. Again, don't let this be confused right here with a P wave. You've got your PJC right here. And lastly, we've got a PJC that shows up right here that has no P wave, probably hidden in the QRS complex, but it does appear prematurely. So that's your PJCs.